Hello students, I'm Dr. Manisha, your Mara faculty for ENT, and today we will be discussing the ENT recall questions of the recently held inicet November 2025. So from the ear we had 3 questions, from the nose we had 2 questions, one from the pharynx and one from the larynx. Let us quickly see what these questions were. Identify the structure marked by the arrow in the image given below. So we can see that the image is a CT scan, and whenever in image based questions, when it is a spot diagnosis, you're not able to immediately see the CT or the image and make out what it is pointing to. See the choices, right? So what are the choices here? Internal aortic canal, external aortic canal, vestibular aqueduct, carotid canal. So yes, by the choices, we at least know now that the structure that has been marked has some relation to the ear. So what we have to see in the CT is the ear part. So yes, this is an HRCT of the temporal bone, and to read the structures, to identify the structures on the HRCT of temporal bone, we need to know 2 things. First, what the temporal bone is like, and second, where the ear in the temporal bone is. And yes, it is very simple. Just be with me. You need not be able to identify each and every structure on the HRCT temporal bone. What is important for you at your level and what can be asked from you, that is all that you need to know. So just be with me. It is very simple. So yes, now what is the temporal bone? See the picture first. We are seeing the temporal bone laterally. We are having a lateral view. So here what we are seeing, this is the squamous part of the temporal bone, and this here is the mastoid part of the temporal bone, right? Now this is the tympanic part of the temporal bone, right? Tympanic part, and this process, all of you know, this is the styloid process, right? Now, can you see that this is complete? This complete is the temporal bone, and in the temporal bone, we can see a canal. Yes, we can see an opening through which we can see a canal. So yes, this canal is what we call the ear. So ear is present in a canal in the temporal bone. That is the first thing that you need to know. That was simple. Okay, now come to the second thing, second part. Now, when we look at the temporal bone from above through the upper surface, through the inner surface of the brain, this is how it appears like. That is the picture 2. Okay. So now here, where are we seeing the temporal bone? So this here is the temporal bone here, right? And what are the parts of the temporal bone that we are seeing here? Right here, this is the squamous part that we saw from the outside also. Here behind the squamous part, we saw laterally was the mastoid part. So that is, this area will be the mastoid part. So now let me rub this. Now very, very important part. Can you see this? This is the petrous part of the temporal bone. This here, the apex is what is known as the petrous apex. And here anteriorly, this is what is the anterior slant. See here, that faces anteriorly towards the middle cranial fossa, and here this is the posterior slant that faces posteriorly, that is towards the posterior cranial fossa. That was also simple. Okay, so now where is the ear here? We are seeing the temporal bone from above, so that is the upper surface that we are seeing in picture 2. Where is the ear here? It is present inside the temporal bone in a canal. So if I draw it, it will be something like this, right? It will be like this. So here we will have the pinna. Here will be the external aortic canal. Here will be the middle ear. Here will be the inner ear. That was also simple. Okay. Now, which means that on the anterior slant here, we will have what we are seeing right now is the roof of the external ear, roof of the middle ear, and roof of the inner ear. Now, let us come to the posterior slant of the petrous part of temporal bone. Now, see the posterior slant. Can you see this opening? Yes, what is this opening? This is the internal acoustic meatus through which passes the 2 nerves. Yes, the 7th and the 8th cranial nerve. From the brain, it will directly enter where? Yes, we have the inner ear here. So it will directly enter inside the canal where we have the inner ear. Is that clear? So that is the internal acoustic meatus. Now, okay, now just have a look at this area. I told you that here we have the pinna and here we have the external aortic canal. So behind the external aortic canal, this is the area of the mastoid, right? This is the area of the mastoid. Okay, so now let me rub this. Now, what is this that you are seeing? Can you see some marking here? This marking here, what is this? Yes, we can see that this is something which is posterior to the mastoid. So what is this? Yes, so this here, this is the transverse sinus. Okay, and this is what continues as sigmoid sinus, the S-shaped sinus. And also see here, the sigmoid sinus is ending here at a foramen. Yes, which is at the same level at the internal acoustic meatus, but it is quite lower down, inferior. Yes. So what is this? This is the jugular foramen. So yes, the sigmoid sinus, it continues through the jugular foramen as jugular bulb. And then it comes out and continues as internal jugular vein. That is also clear. So is it very simple? I will repeat here. We have the anterior slant. Tell me, anterior slant here, what we are seeing is the roof of, yes, the external ear, the middle ear, the inner ear. And on the posterior slant, we have important structures which we need to know. I'm going to tell you only those things which you need to know, which is totally you cannot mistake, right? And on the posterior slant, this opening, what is this? Internal acoustic meatus. And what is this? This is the jugular foramen. And both internal acoustic meatus and jugular foramen have been all-time favorite of your exams. Okay. So now, yes, now come to the third picture. Okay. Now, in the third picture, what are we seeing? We are seeing again the temporal bone, but we are seeing the inferior surface. In the second picture, we were seeing it from above, that is the superior surface. And in the third picture, we are seeing the temporal bone, but from the inferior surface. So here we will be having, inside that we'll be having the canal, the external ear, middle ear, inner ear. And what we are seeing now in third picture is the floor. Floor of the external ear, floor of middle ear, floor of inner ear. In second picture, we were seeing the roof of external ear, roof of middle ear, roof of inner ear. So is that clear? So the ear is present in a canal in the temporal bone. Okay, now in the picture 2, if I ask you where is the jugular foramen? So in the picture 3, if I ask you where is the jugular foramen? Yes, so first we will see in the picture 2. So this here, the jugular foramen is present at the junction of the occipital bone and the petrous part of temporal bone. Yes or no? Yes. So now let us see where that is in picture 3. This is the occipital bone. This is the temporal bone. So somewhere here will be the jugular foramen. And what comes out through the jugular foramen? The jugular bulb, the 9th, 10th, 11th cranial nerves. Yes, so the moment the jugular bulb and the 9th, 10th, 11th cranial nerves, they come out, they immediately lie in relation to the floor of the middle ear. Is that clear? Okay, so we know a lot of things right now about the temporal bone. Yes? Now, if we know this picture 2, what we saw in the picture 2, we know a lot of things on the CT scan, HRCT of the temporal bone, the axial cut. Yes, axial is a transverse cut. Because it is ditto the same, exactly the same. Okay, so now let me first draw in the temporal bone here. What you are seeing, this is the external ear, right? We have the pinna, we have the external auditory canal. So inside the canal, so we have the external auditory canal here, the middle ear, the inner ear. Here will be the internal acoustic meatus, right? Behind here we will see the mastoid air cells, behind which we will see the sigmoid sinus. Now exactly, now let us see on the CT. Are we able to make out? It is so simple. The moment we see this bone here, we know this is the petrous part of the temporal bone. We are having a look at the HRCT of temporal bone. So yes, from outside, we have the external auditory canal. So now we go into the middle ear, right? I will draw as 1, 2. I will mark it as 1, 2. So 1, we are in the external auditory canal. 2, we are in the middle ear. So you will now tell me that, oh my God, we have gone into the middle ear. I cannot make out that that is the middle ear and which is the external auditory canal. You need not make out. All you need to know is that the external auditory canal continues into the middle ear. And how will you know that both of them are, one is external auditory canal, the lateral one, the medial one will be obviously the middle ear. Both of them contain air. So both of them will appear like a continuous, maybe because the tympanic membrane is very thin, right? You might be able to identify it. You might at your level might not be able to identify. But yes, you will be able to identify it is the external auditory canal or it is the middle ear by seeing that it has air. And how does air appear on CT? It appears black. Yes. Okay. So So 1 was the external artery canal, 2 was the middle ear, and 3 is the inner ear. Why do I say 3 is the inner ear? Yes, 3 is the inner ear because that is appearing white, and white is bone. Bone on CT appears like white. Yes, we know that inner ear is bone. Yes or no? It is bony labyrinth, inside which is the membranous labyrinth. So here you will not be asked that identify the structures of the middle ear or inside the inner ear. No, you will not be asked. But yes, by having a look, you should be able to identify this is the external artery canal, and go medial. Again, that is air, that is the middle ear, medial to which will be the inner ear, which is bony labyrinth. So that will appear white on CT. Is that clear? Okay, so now let me mark this area as 4. What is this area? What is this area? Yes, if something like this is going here, this is here the sigmoid sinus. This area is the sigmoid sinus, right? Okay, so now you will be thinking that where is the internal acoustic meatus here? The internal acoustic meatus will be present here, but again, let us come to this part, right? This part. The internal acoustic meatus will be seen when the cut section is at this level. Yes or no? Yes. Whereas if it is a cut section much below, inferior, at this level, you will be able to see the jugular foramen. Now, this CT that we are seeing is neither at the level of the internal acoustic meatus, neither at the jugular foramen. It is somewhere in between, because of which we are not seeing in this area the internal acoustic meatus or the jugular foramen area. Yes. Okay, so now, which means that on whether it is a skull picture that is given to you or it is a CT that has been given to you, what are the things that you should be able to identify without any mistake? Yes, you should know that this is the temporal bone. Inside here will be the external artery canal. We will have the middle ear. We will have the inner ear. How to identify them? I have just told you. Okay. Now here posteriorly, this will be the internal acoustic meatus. And here this is the area of the jugular foramen. So now you will tell me that, okay, if it is a superior cut or inferior cut, how will we be able to make out that it is superior or inferior? What we are seeing is the internal acoustic meatus, all the jugular foramen. You need not know that also. Why? Because if they are showing you the jugular foramen cut, they will ask you that this patient, some presentation will be given that this patient is a patient who has pulsatile tinnitus with conductive hearing loss. And you know that, yes, this patient has a glomus jugulaire. Yes, like this was a question that was given last year in your exam. This was exactly the presentation. Patient presents with pulsatile tinnitus, conductive hearing loss, red mass was seen behind the tympanic membrane, and then the CT scan was given for you to identify the jugular foramen area. So then it will be very obvious that what they want you to see is the jugular foramen area. Is that clear? So they will not give you anything which is out of your level to understand or to identify. Is that clear? So now, all these things we know. We know this foramen, we need this foramen. We know that here we will have the sigmoid sinus area, right? Okay. Now, let me ask you this. What are you seeing in this area? What is this? Yes, so yes, this you must have read in your anatomy also. The base of skull, very, very important. So this is the carotid canal. Carotid canal, and yes, listen to me carefully. The internal carotid artery, where it exits the temporal bone, the petrous part of temporal bone, it exits from the carotid canal. And then, can you see this foramen? What is this foramen? This foramen is the foramen lacerum. So then the internal carotid passes over the foramen lacerum to enter into the cavernous sinus. That part is known as the cavernous part of the internal carotid. We know all this. Do we know that? We should be knowing all this. So yes, does the internal carotid also pass through the temporal bone? Yes. What are the parts of the internal carotid? The first part is the cervical part in the neck. And then it enters into the temporal bone, that is known as the petrous part. And then when it exits the petrous part, it enters into the cavernous sinus, that is the cavernous part. Yes. So now, what are in the petrous part of temporal bone, how does the internal carotid go? So see that again, that is very easy. So this here, we have read it again and again that we have the internal carotid. Yes, this part is known as the cervical part. and then it enters the pitris part of temporal bone, that is the pitris part. And while it is entering into the pitris part of temporal bone, it is in relation to which wall of middle ear? Yes, this here, it is in relation to the anterior wall. So let me mark this as, yes, like this. So this here is the anterior wall, right? In relation to the anterior wall, we have the internal carotid. That is why the anterior wall of middle ear is also known as the carotid wall. Now let us have a look at the third picture. So in this, here is the third picture. In the third picture, yes, from the neck will be going the internal carotid, and it will go anteriorly in relation to the anterior wall of the middle ear. Is that clear? Now, what is most important is to be able to identify where the internal carotid is in the third picture, or in the second picture, right? In the second picture. So here, the moment the internal carotid enters the pitris part of temporal bone, it will be first vertical, then it will take a turn, right? That is, and then it will run horizontally. Where? In relation to the anterior wall of the middle ear, we know that. So now let us see, where is the middle ear? This here we know is the middle ear, right? Somewhere here will be the middle ear. So in relation to the anterior wall, when we draw, so it will take a turn, and in relation to the anterior wall, here somewhere will be the internal carotid artery, and then it will exit through the carotid canal, and then it will enter into the cavernous sinus part. So which means that if we have a look at this picture here, the first picture here, yes, the internal carotid will be in relation to the anterior wall of the middle ear, and this is the carotid canal through which it will enter into the brain, passing over the foramen lacerum into the cavernous sinus. This also we must have read so many number of times in anatomy. So all that we are doing is we are recapitulating, we are just combining everything together. Now in this second picture, yes, let me ask you, if I mark this, what will this be? We know that this is somewhere in the area of the temporal bone. Yes, this is posteriorly below that we are seeing immediately another thing also. So the thing that is above is the internal acoustic meatus. The thing that is below this one, what is this? This is the jugular foramen. Was that not simple? Okay, so now in the CT, you should be able to identify first the external auditory canal, the middle ear, the inner ear, we know that. Okay, the internal acoustic meatus, we know that. Jugular foramen, we know that. The sigmoid sinus, we know that. And carotid canal, do we know that? Yes, we know that. So now let us come to this question again. So what we have to identify is what is the structure that has been marked. Now, even without seeing the choices, if you see the structure that has been marked by the red arrow, we know that this here is a temporal bone that we are seeing, right? So it is something, yes. What is that? That looks like internal acoustic meatus, yes or no? Yes. So let us see internal auditory canal. We have that in the choice. External auditory canal. Where is the external auditory canal here? Let us see on this side. So just in front of the mastoid, can you make out the mastoid air cells? Yes, we can make out. This here is the mastoid air cells. So just in front of the mastoid, we will have the external auditory canal. So we are seeing the external auditory canal here. In continuity with it will be the middle ear. Yes. And then we have this white bony structure that is the inner ear. This all will be the inner ear. And we have this connection between the inner ear and the brain. What is this? This is the internal auditory canal. Is that clear? Yes. So that is what you're seeing here. This is the internal auditory canal. Okay. So this cannot be the external auditory canal. Any doubts in that? Yes, external auditory canal will be on the outer surface, right? It will be on the outside. It will not be on the medial, on the this side of the pitris part of the temporal bone. It will be on the outer side, not this side. Now, what about vestibular aqueduct? First of all, do you need to know how to identify the vestibular aqueduct on the CT? Absolutely no. Will they ever ask you? No, no, no. They will not ask you, right? But still, now I am just telling you that where is the vestibular aqueduct? Vestibular aqueduct, what exactly that is? That is the bony covering of the endolymphatic duct. Endolymphatic duct, the bony labyrinth over the endolymphatic duct is what is known as the vestibular aqueduct. So that is somewhere that will be on the posterior surface of the mastoid air cells, and that opens like this, right? It is totally in the opposite direction. The opening of the internal acoustic meatus is like this, and the vestibule aqueduct is just opposite to that. Do you need to know this? You do not need to know this. Yes, but yes, what I am just telling you, because it is there in the choice and they will not ask you, right? And the carotid canal, again, there is a rare possibility, but they can ask you. Why? Because that is something, the carotid canal, the foramen lacerum, all that is something that you need to know, otherwise also in the base of skull. Yes, so now if in this picture, if I mark something, if I try to mark the carotid canal, where will that be? Yes, so again, come to this picture. How to identify the carotid canal? The carotid canal, just see, it is at the petrous apex area. It is on the anterior part of the petrous apex. And also it is very, very close to this bone. What is this bone? This is the sphenoid bone. Here we have the clivus. So it will be very adjacent to that, right? So now let us see on the CT if we are able to make out. We have the sphenoid here, we have the clivus here, which means this will be the petrous apex part. So very close to the apex. Carotid canal means internal carotid. How will that appear? Will that appear black? Will that appear white or gray? Fluid appears grayish, different shades of gray. Yes, so this here what we are seeing, this is the carotid canal. Is that clear? So you have to look at it at a calm mind, and yes, once your mind knows how to see the pictures, how to see the structures on the HRCT, you will definitely be able to identify them. And that is all that you should be able to identify on an HRCT of the temporal bone. Is that clear? So what's the answer here? It is internal acoustic meatus. Now let me check if you are able to identify on this CT. Let me mark 1, 2, 3, 4, 5, and yes, this is a test for you. What is 1? Yes, so the moment you see, you first are able to identify this is a part of the temporal bone, which means this is here. So this air thing is, yes, this is lateral, so this is external aortic canal. What is this thing marked by arrow? That will be middle ear. What will be this thing? Yes, that will be the inner ear, the bony labyrinth, inside which we are seeing that grayish membranous labyrinth. You can see this, yes? So that is the membranous labyrinth. Okay. Now let me mark this structure on the other side or this structure on this side. Now tell me, what is that? Yes. Can that be carotid canal? Yes, that is the carotid canal. That is the carotid canal. What is this area? This is the area of the sigmoid sinus. Again, in this picture, this is a cut somewhere in between the two foramen, the internal acoustic meatus and the jugular foramen. So you are not seeing any of them. But if there is some foramen marked here like this, for example, if there is something here, what can it be? Yes, this is the internal acoustic meatus. So now when you see this, you will be able to make out immediately. Now, why do I say that you should know only these things in the HRCT of the temporal bone? Yes, because HRCT of the temporal bone, we take in very minute millimeters cuts so that we are able to see the entire ear, which is, packed in a small canal in the temporal bone. So yes, you will not be able to make out the individual slices, individual ossicles and all those things. Even as we are seeing in this CT, this is a CT which is very much above where we are seeing the internal acoustic meatus. It is one of the higher cuts as I showed you earlier. So maybe you are not able to see the external aortic canal also because the external aortic canal starts a little lower down. So what you are able to see is the mastod air cells, and then medial to that you will see some air in the epitympanum and then the inner ear. So if they give a CT like this, they will definitely not want you to identify the external aortic canal, which is not seen in this CT. If they want you to identify the external aortic canal, they will give you a CT, a cut where you are able to see external aortic canal very, very clearly, and you will not be able to mistake it. For example, in this CT, will you ever be able to mistake if this is the external aortic canal or not? Will you ever be able to mistake this is mastod air cells or this is carotid canal? No, you will not. Yes. So here, if they ask you, what they will ask you is this thing. So it has to be, you should just know the orientation. Yes, some things you should know, and these other things, if you know this much, that is sufficient for you. Was that simple? So the next question we have here, a 60-year-old man presents with gradual progressive hearing loss. On examination, he has difficulty perceiving high frequency sounds, but other findings are normal. Which structure is primarily affected in this condition? So here we have an elderly who has a high frequency hearing loss, and that is slowly and progressive. So which means that this patient is having presbycusis age-related hearing loss. So what we are supposed to identify is which structure is primarily affected. In this condition, stria vascularis, tectorial membrane, inner hair cell of basal turn, outer hair cell of apical turn. High frequency sensed by. Very good, the basal turn of cochlea. So what should be the answer? It should be C, basal turn. Yes, don't get confused that always earlier to be damaged is the outer hair cell. So should it be outer hair cell of apical turn? No. The high frequency means it is basal turn. Apical turn means it will be the low frequency. Yes, earlier to be damaged is the outer hair cells, but outer hair cells of the basal turn, if we are talking about high frequency hearing loss, right? Later on, the inner hair cells are damaged. But if we talk about early, then yes, earlier to be damaged is the outer hair cells. If there is high frequency affected, then it will be basal turn. If it is low frequency affected, then it will be apical turn. Is that clear? The next question, which of the following modalities is not used for hearing assessment in an infant? So the choices that we have here is brainstem evoked response audiometry, that is BERA, autocaustic emission, pure tone audiometry, free field audiometry. What is the answer? Yes, I know what the answer is. So how do we do BERA? Yes, here we pass a probe in the external auditory canal which gives a sound. Electrodes are attached all over the head of the patient. As the sound travels in the auditory pathway, it is recorded in the form of a graph which has waves. So we give a sound, we record back the result in the form of a graph. Do we require any cooperation from the patient? No. So this is an objective test. Can we do it in an infant? In a neonate? We can do it in an infant. Yes, in fact, has been a question asked so many number of times earlier. Which are the objective tests? Which are the subjective tests? This year, they ask the same thing, but just the language has been changed. So yes, we can do BERA in an infant. What about this test? Yes, this is autocaustic emission. How do we do this? We pass a probe in the external auditory canal. Now, through this probe, a sound is given, which travels from the external auditory canal into the middle ear and then into the inner ear. It stimulates the organ of Corti. And in the organ of Corti, the activity of the outer hair cells produces a sound which is loud enough to travel back into the middle ear and then from the middle ear into the external auditory canal where it is picked up by the probe. So again, do we require any cooperation of the patient here? Just passing the probe, recording the result? No. So this is also an objective test. In fact, this is the most common test that we use for screening hearing in neonates. That's the repeated question. So yes, this we can do in infant. What about pure tone audiometry? Can we do it in an infant? Here, the audiologist will sit outside. The patient is made to sit alone in a closed room and a sound is given. When the patient hears the sound, he responds, and that is how we know that the patient heard the sound, which means it is totally a subjective test. A lot of cooperation from the patient is required. Will you be able to do it in an infant? No. At 2 years, 3 years? Remember that pure tone audiometry is not reliable before 5 to 7 years, which means that only when the child is around 7 years or maybe after 5 years, we will be able to do pure tone audiometry. That up till 5 years of age in all children, the first test that we will be doing will be either a autocaustic emission or a BERA. Tell me, if an adult comes to you with any hearing loss, what is the first test that you do? Do you, any patient is telling you that I'm having hearing loss? Do you say, oh, you have hearing loss, then let me get BERA done or autocaustic emission done? No, that is not what we follow. That is not the sequence. Yes, what we do is whenever adult comes with hearing loss, we examine. We do pure tone audiometry. Then we do tuning fork. Then we do pure tone audiometry, right? Whereas in an infant, up till 5 years, whenever the child will come with hearing loss, will we always advise an autocaustic emission or a BERA as the first test? So does it mean that before 5 years of age, the only test that we have is a BERA or autocaustic emission? Any child comes with hearing loss, the first test that we will ask for is a BERA or autocaustic emission. Is that true? No, that is not true. Now, if an adult comes to you in the OPD with the complaint of hearing loss, what is the first test you get done? Yes, you examine the patient, you do a tuning fork test, and then you go for a pure tone audiometry. You never say, okay, you have hearing loss, go for a Bera or go for autoacoustic emission. No, what is the sequence? You do tuning fork and then you do pure tone audiometry. If the pure tone audiometry shows a sensorineural hearing loss, then you want to find out it is sensory or neural, then you go for autoacoustic emission, then you go for Bera. Is that clear? Yes or no? Yes. So what about the hearing test in children? When a child comes with hearing loss, what is the first test? Do we have any replacement for pure tone audiometry? Yes, we do have a replacement for pure tone audiometry. We know that children will not tell you that I'm hearing the sound or not, but in response to the sound, their behavior will change. So we observe the behavior of the child, the change of behavior of the child in response to the sound, and then we make out whether the child heard the sound or not. That is what is known as behavioral observation audiometry. So before 5 years of age, the replacement of PTA is behavioral observation audiometry. And this change of behavior we can notice very, very clearly after the child is 5 months of age. So which means that when the child is born up till 5 months of age, usually the test that we do is either Bera or autocaustic emission, which is totally an objective test. But after 5 months of age, we have something which is a replacement of pure tone audiometry, and that is behavioral observation audiometry. How do we do that? Now here after 5 months up till 2 years, we can do this test which is known as free field audiometry. Now we know that after 5 months of age, whenever the child will hear a sound, he will turn the head to that particular side. So this is what we use to see if the child heard the sound or not. Right? So what we do in free field audiometry is that the child is made to sit on the lap of the mother, and speakers are placed all around in the room. Sound is given from a particular speaker on one particular side, and it is seen that in response to the sound, the child appropriately turned his head to that particular speaker which was producing the sound or not. If yes, it means that the child heard the sound, and we can accordingly plot the audiogram of the child. Is that clear? That is what is free field audiometry. Now, we know that children lose their attention very fast. Even if he will hear the sound from a speaker, the child might not feel like turning his head. The child might be busy looking at something else, and he will not turn the head, right? So to maintain the interest of the child, what is done is that at each of the speakers, a toy is placed. And if the child has appropriately turned the head to the source of the sound, to the particular speaker which was producing the sound, as a reward, the toy which is placed on that particular speaker is made to play. So the child will now be interested. He will wait for the sound, and the moment he hears the sound, he will turn his head accordingly, and then he wants to see the toy playing. That is what is known as visual reinforcement audiometry. And when the child is a little older, that is from 2 to 5 years, now the child will not only be able to localize sound, the child will now be able to understand what we are speaking. The child will be able to respond. So now we can make the child play a game in response to some sound. That is what is known as play audiometry. So yes, before 5 years, these are the tests that we can do. So can you do behavioral observation audiometry like free field audiometry or visual reinforcement audiometry in an infant? Of course, we can do it. So here, what is the answer? Not used will be Bera, autocaustic emission, pure tone audiometry or free field audiometry. Yes, it will be pure tone audiometry. The next question. Arrange the following steps of functional endoscopic sinus surgery, that is FES, in the correct order. First is visualization of the maxillary sinus ostium, bulectomy, uncinectomy, removal of posterior ethmoid cells, penetration of basal lamella. What is the order? What is the first step? Do we know that? Yes, of course we know that. We know that it is uncinectomy. So let us see which choice has 3 as the first thing in the sequence. A, 3 and C3, which means that B and D is automatically ruled out, right? Okay. Do we know the next step? Once we remove the uncinate, yes, we immediately are in the infundibulum where we have the maxillary sinus ostia. So we approach the maxillary sinus ostia, we widen it, and then we enter into the maxillary sinus, we remove the disease from there. Right? Yes. So the next is visualization of the maxillary sinus ostium. So that is 1. So after 3 should be 1. So let us see which choice A has. After 3, 1. This can be. C has 2. So only with this much knowledge, you can make out that the answer is A. Yes. You do not need to know the next steps also. But still, what do we know? Yes, we know that in FES, what we do is, we first do the uncinectomy. So yes, in the picture 1, this here in the center is the septum. This is the middle turbinate. And here, in between the middle turbinate and the lateral wall, right, that is what is the middle meatal area. So here we are seeing lateral to the middle turbinate, the middle meatal area in which this is the uncinate process. Here is the bulla. In between them is the hiatus semilunaris, through which you enter into the infundibulum. This is the infundibulum, into which opens the maxillary sinus ostia directly, which means that the ostia, the opening of the maxillary sinus, is hidden by the uncinate. Now, how do we operate in the middle meatal area? To operate it, we use endoscopes. So, and they are rigid endoscopes. So, how are you supposed to pass the rigid endoscope here and then here? We cannot. So, whenever we have to approach the middle meatal area, whenever we do functional endoscopic sinus surgery, it is known as endoscopic because we operate with endoscope. It is known as functional. Why? Because here we restore the function of ventilation and drainage of the sinuses. We remove all the disease. We widen the ostia. Yes. So how are we going to do that? Yes, so for doing that, we will have to first remove the uncinate process. Now just imagine, once you have removed the uncinate, you can directly go into the maxillary sinus. You can then approach the ethmoid. The bulla ethmoidalis is the largest anti-ethmoidal air cell. So you can then approach the ethmoid. So that is the sequence. The first step will be uncinectomy. You then enter into the maxillary sinus. You widen the ostia, remove the disease from the maxillary sinus, and then you go into the ethmoids, the anti-ethmoids. Okay. Okay. Now come to the picture 2. In the picture 2, tell me, what are you seeing? This here, see this? This is the uncinate bone, right? And this here is the bulla. This here is the middle turbinate, which we have cut. This is the middle turbinate. Okay. So now that we have identified, let me rub this. So what we will do is, first we will remove this. We will remove this uncinate process. Once we have removed that, we will directly be into the infundibulum, where we will see the maxillary sinus ostia. So we will approach the maxillary sinus. Next, we will go into the anti-ethmoids. That is what is, we are opening the bulla. You can call it anti-ethmoidectomy. You can call it bullectomy. Yes. So now, suppose there is disease in the posterior ethmoids also. Where is the posterior ethmoid? Posterior ethmoid is present here in the superior meatus. Yes. So how do you go from the middle meatus into the superior meatus? Now see this carefully. This is the middle turbinate. This part of middle turbinate which separates the anterior ethmoid from the posterior ethmoid. This is what is known as basal lamella. This is known as basal lamella or ground lamella. Right? And then you pierce this basal lamella or ground lamella and you will reach the posterior ethmoids. So then you will remove the disease from the posterior ethmoids, right? And then from here, you will go into the sphenoid sinus, for which you just need to go a little posteriorly. You need not pierce the superior turbinate to enter into the sphenoethmoidal recess, right? So you just go a little posteriorly, you will see the opening of the sphenoid sinus. Is that clear? Now, even if you did not know the last steps, yes, by just knowing the first few steps, you could answer the question. So, by reading the choices, if you feel that you're not knowing some points or some choices, don't panic. You will still be able to come to the answer. The next question, identify the nerve being blocked in the local anesthesia procedure shown below. So yes, what is shown here, we can see that this is the oral cavity where the anesthesia is being given medial to the third molar on the palate. Yes. So what is the nerve being blocked here? The greater palatine nerve, the maxillary nerve, infraorbital nerve, or anti-ethmoidal nerve. Yes, without any doubt, this is the greater palatine nerve. Yes, this is the nerve which is blocked whenever we want to operate in the heart palate area or on the tooth area, especially in maxillofacial surgeries. This block is done very commonly. So now some of you will ask that, okay, Greater Palatine, is it not a branch of maxillary? So can we not mark maxillary also? No, if Greater Palatine is in the choice, you will mark Greater Palatine nerve. Is that absolutely clear? So yes, where do you block the Greater Palatine nerve? Yes, this here is the Greater Palatine foramen medial to the third molar. That is where you block it, right? And in the choices, we also have the maxillary nerve, intraorbital and anti-eighth model nerve. Where do we block them? Have been questions earlier in your exams. So do we know that also? Yes, we know. Here what is being done is, yes, the Greater Palatine foramen, so Greater Palatine nerve is being blocked here. What is being done here? Yes, here we can see that the anesthetic is being passed where? Just behind the middle turbinate at the sphenopalatine foramen area. We know that through this foramen enter the branches of the maxillary nerve, which give the nerve supply to the nose. So what is being blocked here is the maxillary nerve, right? And also through the foramen, we can inject the anesthetic into the sphenopalatine fossa area to block the sphenopalatine ganglion. So the sphenopalatine ganglion can also be blocked through this route. Is that absolutely clear? Where do we block the intraorbital nerve? At the intraorbital foramen. Where is that foramen? That is here below the, yes, below the floor of the orbit. So we can either anesthetize the intraorbital nerve directly at the foramen, or to reach the foramen, we can go sublabially and then anesthetize the intraorbital nerve. Absolutely clear? Okay, so now what is being anesthetized here? Yes, so we should know what is the nerve that is present here. So just see here, this foramen that we are seeing is a supraorbital fissure. Last year, this foramen was marked and was asked, compression of this foramen will lead to anesthesia of which areas? Yes, so yes, we have the nasociliary nerve here. Coming here, it gives the posterior model branch, the anterior model branch, and it ends as infratrochlear here. Yes, so which means that when we have to anesthetize either the nasociliary or the anterior model, how do we approach it? Yes, we will go along the medial wall of the orbit, and when we go 1.5 centimeters deep, we will be blocking the anterior model. 1 centimeter further deep will be the posterior model. Yes, so if this picture is shown to you, the picture 1, and is asked which nerve is being blocked, tell me. Yes, either anterior model not in choice, then nasociliary, right? Where is the infratrochlear block? Yes, for infratrochlear, see the picture 1. The block will be at the medial end of the brow. So this is the upper end of the eyebrow. This is the medial end. Just medial to that will be the intratrochlear. Is that absolutely clear? Now, again, you should know that yes, this picture 1 is the Greater Palatine block, but this approach can also be approached to block the sphenopalatine ganglion. How? Yes, so just see here. Here we have in the picture 2, this is the maxillary sinus. Anteriorly is the maxillary sinus. Here, this is the pterygoid plate, right? In between them, this is the sphenopalatine fossa area. And in the sphenopalatine fossa, we have the pterygopalatine ganglion. And here, the branches of the sphenopalatine ganglion, which are the branches of the maxillary nerve, also, yes, they, like the Greater Palatine, they pass from here inferiorly, and here we have the Greater Palatine foramen, which means that through this foramen intraorally, we can also inject anesthetic into the fossa to block the sphenopalatine ganglion. Is that clear? Okay, so now, so what is the nerve being blocked here? Yes, it is the Greater Palatine nerve. The next question is, which of the following is not involved in either dysarthria or dysphagia? Okay, so what are the things that have been marked? Can you make out what is A? Yes, just see here, A is something in the nasopharynx. Yes, we can see it is behind the inferior turbinate, the eustachian tube area. Some students said that the muscles were named in this question, like tensor palati. Yes, tensor palati is a muscle of the palate, but its main action is to open the eustachian tube. So probably by nasopharynx marking the eustachian tube area, that is what they want to show. Okay, now what is 2? 2 is the palate, the soft palate. Soft palate. What is 3? 3 is, can you make out? Yes, that is the tongue. And 4, that is the area of the pharynx that is behind the oral cavity. So that is the oropharynx, right? Okay. Now, what is dysphagia? Dysphagia is difficulty in swallowing. So whenever there is any abnormality when the food passes from the mouth up till the stomach, that can lead to dysphagia. So can any abnormality of the tongue lead to dysphagia? Of course. Soft palate, what role does the soft palate is in swallowing? Whenever we swallow, the soft palate moves posteriorly to meet the posterior pharyngeal wall, to meet the passivant ridge, and it closes the nasopharyngeal isthmus so that food only goes down, it does not go into the nasopharynx. So yes, any abnormality can lead to dysphagia. And what about the oropharynx? Of course, all the pharyngeal muscles are the one that mainly push the food down into the esophagus. Any abnormality of esophagus can also lead to dysphagia up till the stomach, from mouth to stomach. Any abnormality can lead to dysphagia. What about nasopharynx? No. So this will not be involved. So we know that that is one. This will not be involved. Okay, so even if we know what is dysphagia, we can come to the answer that this will not be involved. So which means that A is the answer. What is dysarthria? Yes, dysarthria is difficulty in producing speech. And we know that for producing speech, the vocal cords vibrate. Yes, but these vibrations have to be turned into speech. And that is what we call as articulation of speech, right? And for articulation of speech, for articulation of words, what do we need? Yes, we need the lips, the tongue. We need the, whenever we are speaking the consonants, which the words, which the alphabets, which do not have to pass through the nose. Again, the soft palate will move posteriorly to meet the passivant ridge or the posterior pharyngeal wall. Or when we are speaking the words which have to pass through the nose, then this soft palate will not move posteriorly and this will be open, right? So soft palate has a very important role in articulation of speech. So, and what about oropharynx? Yes, the pharyngeal constrictors. They constrict in a different manner when we speak different consonants. So all of these from the lip up till the vocal cords are important for articulation of speech. Any abnormality from lip up till the vocal cords can lead to any dysarthria, difficulty in producing speech, right? So again, we know that what is not involved, that is definitely the eustachian tube area, the nasopharynx. So again, we come to the same answer, that is one, that is A. So even if you could just by dysphagia make out, you were on the answer, right? So now coming to the next question. According to the 8th edition of AGCC guidelines, what is the T stage in a patient with laryngeal carcinoma involving the entire right true vocal cord, which is immobile, anterior commissure, anterior 1/3 of the left true vocal cord with invasion of inner cortex of the thyroid cartilage and paraglottic space on radiological imaging. So they have given us so many hints here. We need to identify what is the T stage. Is it T1, T2, T3 or T4? Tell me, what is it? What do we see in the question to immediately say it is T3? Yes, the vocal cords fixed. So here it is clearly mentioned that the vocal cord is immobile, which means that yes, it is not T1 and not T2, cannot be T1, cannot be T2, it is T3 and more. Yes, so now what we need to see is further what is given is that the inner cortex of thyroid cartilage. Yes, so what is T4? T4 means that it has completely invaded the thyroid cartilage and it has gone out of the larynx. If there is only inner cortex involvement of the thyroid cartilage, that is T3, right? So here it is T3. So how do we find out whether it is T1, 2, 3 or 4? Yes, it is very simple. Just be with me. Now the T1 tells you that only one site of the larynx is involved. What are the different sites of the larynx? Glottis, subglottis or supraglottis, right? So now listen carefully. If only the glottis is involved, that is T1. Only subglottis is involved, it is T1. Whereas in the supraglottis, because it is such a big area, yes, if we say that there is a small tumor on one vocal cord, that is T1. Whereas if the entire supraglottis is involved, that is T1, that will not be fair, right? So in the supraglottis, what is T1? T1 means only one subsite of supraglottis is involved. What are the subsites of supraglottis? We have epiglottis, we have ariepiglottic fold, we have false vocal cord, right? These are the different subsites of the supraglottis. Okay, so which means that what is T1? T1 means it is only one side that is involved, either only the glottis or only the subglottis, but in the supraglottis, only one subside of supraglottis that is involved. Now, in the vocal cord, that is the glottis, we have two vocal cords. So, T1 of glottis is divided into T1A and T1B. When there is involvement of only one vocal cord, that is T1A. When both the vocal cord, that is T1B. Is that very clear? That was very simple. Now, what is T2? T2 tells you that two sides which are adjacent are involved. For example, from the glottis, the tumor has gone to the subglottis or it has gone to the supraglottis. So, two adjacent sides are involved. Or when we are talking about supraglottis, then two adjacent subsides are involved. For example, from the epiglottis, the tumor has gone to the ariepiglottic fold. So, two adjacent subsides in the supraglottis or two adjacent sides are involved. That is the T2, right? Now, what is T3? The most important thing that you need to know is that if the vocal cords have become fixed, it is T3, which means that in T1 and in T2, what was the mobility of the vocal cord? It was mobile. Is that clear? So, which means that if one vocal cord is involved, but it is mobile, then it becomes a T1. Whereas if one vocal cord is only involved, but the vocal cord is fixed, then it immediately becomes a T3. Is that clear? So, the moment you see the vocal cord fixed, you know it is T3. Now, there are certain other extensions of the tumor also which make the tumor T3. Yes, so what is tumor? When do we call it as T3? When it is going out but still within the confines of the larynx. For example, it has gone anteriorly into the pre-epiglottic space, or it has gone laterally into the paraglottic space, right? Or just see here, when it has gone anteriorly and involved only the inner cortex of the thyroid, that is T3. Remember that if there is through and through extension through the thyroid, it means now it has gone out of the larynx, then that makes the tumor T4, right? So when it is out of the larynx, but yes, nearby, that is what is T4A, which means it has penetrated through and through the thyroid. It has gone to the strap muscles, to the thyroid, it has gone to the trachea, it has gone posteriorly to the esophagus or to the tongue muscles. All that is T4A. It is out of the larynx but nearby. And if it is out of the larynx but distant, like prevertebral space, mediastinum, carotid, then that is T4B. Was that simple? So there are some catchy things that you need to learn whenever it is asked in your exam. Yes, what you need to find out first, C is mobility. Was asked last year in your exam that yes, there is a tumor which is involving both the vocal cords, but the vocal cords are mobile. Yes, so that is T1B. Most commonly asked is vocal cords are fixed. Yes, why you need to know it is T3? Because from T3 onwards, the management of the tumor changes. In T1 and T2, you can either go for a transoral laser microsurgery or in radiotherapy, except when the tumor is mid-cord, only one vocal cord is involved, then you only go for TLM, right? Otherwise, T1 and T2, you can either go for TLM or you can go for radiotherapy. Whereas the moment the tumor becomes T3, then your management changes. So that is why the most common thing that is asked in your exam is T3. Yes, so management changes from TLM or radiotherapy to concurrent chemoradiation. So we should know when a tumor has become T3, right? Again, we should know when the tumor has become T4. Why? Because then the management will again change to a total laryngectomy plus radiotherapy. So that is why what makes a tumor T4? Yes, when there is complete cartilage invasion. And that is again another question of your exam, that if we actually want to see the cartilage invasion, which will be a better investigation, a CT or a MRI? MRI, yes. So those were some very, very important repeated questions that were asked from carcinoma, staging of the carcinoma of the larynx. So those were the questions from ENT in the recently held inicet 2025.